All right, excellent. Thank you for joining us. Welcome to VesCell Health Talks number 15. We are thrilled to have you. We meet every week to talk about angiogenic cell precursors that are transforming care for ischemic disease. Today, we're focusing on data and content specifically for vascular surgeons. That particular group of surgeons has the challenge of helping patients with critical limb threatening ischemia, meaning there's a risk of amputation due to ischemic disease in the legs and in the feet, largely caused by peripheral arterial disease. This is a data review, and we're going to be talking about how angiogenic, which means cells that regrow blood vessels, and autologous cells, cells that are from a patient's own stem cells, can help restore blood flow, reverse ischemic disease with a patient's own cells. So let's dive in and let's learn about the data that we have generated for over a decade of clinical studies. Decision support is the focus today for vascular surgeons and how to navigate really a cell therapy revolution, if you will, going from managing patients that are very sick to potentially, and in an investigational way, going towards healing and, dare I say, curing. Cell selection and safety for no-option patients, looking at clinical evidence. We'll look at cell culturing, administration protocols, and patient selection criteria. So these are the topics for today. We're going to be unpacking our phase 1 and phase 2 studies. Those are the true north for everything that we do. And so the takeaways, just to say it again, for your patients that are no-option patients with CLTI, we're going to help you understand what are the right cells to consider or to select for that patient. Look at the evidence so that you can make the most informed decision possible. We're going to talk about cell culturing, how the cells are transformed from clean stem cells into cells with very specific functionality that regrow blood vessels. How to administer, meaning how to inject the stem cells into the calf muscle. And then who are the appropriate patients and who is not. And so we're going to talk about the inclusion and exclusion criteria. The next webinar that we have, we're going to talk more about pricing for cell therapy in a pre-reimbursement world. As we go through phase 1 and phase 2 studies, there are certain states and there are certain countries around the world that believe stem cell therapy is important, that it's safe, and within specific guidelines and rules and regulations, they may be offered in advance of FDA approval. So we're going to talk about how patients can access care. How do we democratize care? Make it available to everyone in the context of pre-FDA approval and also pre-reimbursement. And we have some solutions that we're going to talk about. Hemostemix, founded in 2003, is an autologous stem cell therapy platform and winner of the World Economic Forum Technology Pioneer Award. Hemostemix has been developing and patenting, scaling autologous blood-based stem cell therapies for over 20 years. We've had 318 subjects in 7 clinical studies and a total of 498 patients treated and 12 peer-reviewed publications that are quite compelling. That's our true north. We hope you'll look at those studies as we do, as our guidance for the topics that we've just introduced. Know that ACP-01 is investigational. We have ongoing safety and efficacy studies for a number of ischemic diseases, from the heart to the limbs, even to the brain. So we are looking not only at peripheral arterial disease and chronic limb-threatening ischemia, but non-ischemic dilated cardiomyopathy, ischemic cardiomyopathy, heart failure, angina, and then vascular dementia, which as you probably know, is the result often of a major stroke or a series of microstrokes that can cause blockage, the blood flow to the brain, leading to cognitive impairment. We think that's a very promising, exciting area of therapy for Hemostemix. We are very active in the community. We hope all the vascular surgeons online enjoyed The South Florida Society for Vascular Surgery, that was just last weekend, October 24 to 26, a great meeting. November 12th, we're hosting a CLTI roundtable with vascular surgeons that are partnering with us at the University of Miami. Our Chief Medical Officer, Dr. Fraser Henderson, will be presenting our data, offering new regenerative insights and case experiences with CLTI. We will see you in Key West at the Innovations in Wound Care Summit, and then in February and in June for society meetings coming up. We're looking forward to seeing you there. Let me introduce ACP-01, angiogenic cell precursors, in the context of its mechanism of action, how it uses the cell precursors to migrate to the sites of injury where there is ischemia to promote new blood vessel growth, reduce inflammation, and enhance tissue repair. We've talked about the conditions that we have under investigation, and you're going to see us talk about the body of knowledge relative to safety and outcomes data that helps guide us really towards our phase 2 and phase 3 studies coming up, and we're going to share that data with you today. This is a list of our peer-reviewed papers in cardiomyopathy, angina, CLTI, wound care, limb salvage, and we'll be referencing some of that data today. We want to recognize Florida and their legislative leadership that has given a path forward for cell therapies that really is landmark legislation where cell therapies under specific guidelines are authorized for use in advance of FDA approval, and there are explicit scopes of treatment and patient safety standards that we will adhere to. There are a number of states, Texas, Arizona, Utah, Oklahoma, Missouri, Georgia, that are following suit or actually have already passed their own legislations. We will seek to understand those, and we will attempt to run our clinical trials and offer care where we have legal pathways. In the United States and around the world, there's a global opportunity for regenerative care. We've talked a little bit about the mechanism of action, the two keywords, angiogenic, restoring blood flow, autologous, from your patient's own cells. That matters as it relates to how we isolate and prepare the cells using our proprietary technology. There are no invasive bone marrow aspirations required. The angiogenesis activation helps improve circulation and oxygen-starved tissue, inflammation reduction to help create an optimal healing environment, paracrine signaling, releasing growth factors to activate the body's natural repair mechanisms, and then targeted delivery where our cells home into the sites of ischemia, and we'll be unpacking that MOA in all of our conversations. Peripheral arterial disease, often as a function of the Western diet, is a growing health crisis, and everyone is focused on that. 3 to 10% of our general population, 20% of elderly, with a strong connection to diabetes. As it relates to end-stage PAD, 50% of patients do undergo revascularization procedures to improve blood flow into the lower extremities, including bypass and angioplasty, but they're limited options. So 45% of patients are not eligible for revascularization. And so we're seeking to offer a new option in the context of our clinical studies and in the commercial pathways where we can legally offer VesCell. For CLI patients, the mortality rate is 15 to 20% within 6 months and may exceed 50% at 5 years. We do consider and look at this from the context of life extension and longevity and mortality, and what is the impact of amputation. And for diabetic patients, if the amputation rate is 10 to 40%, mortality can rise to 50% among that patient population. Let's dig into our studies. These are our 7 safety and efficacy phase 1 and phase 2 studies across cardiomyopathy, angina, heart failure, CLTI, and wound care. And we're going to talk about the Henderson study. We're going to look at that in a second, and then make some references to Szabo and Multiranga as we dig in here. There was a death. There was an unrecognized myocardial infarction 2 weeks before an administration of the cell therapy. The death is attributed to that MI and does not seem to be attributed to the cell therapy itself. Across the 298 patients that have taken ACP-01, It is largely thought to be safe, and that is in part because it's your patient's own cells. The blood draw is an office procedure. It avoids anesthesia. There are no complications associated with bone marrow harvest. There's a general perception of safety of autologous cells, and we provide a series of reference documents in that regard. The autologous cells have no risk of tainted blood or blood products, no parasites, no viruses, no pathogens, no risk of neoplasia from pluripotential cells, and no ethical concerns as with fetal tissue. That's a big part of the Florida legislation. I'd recommend everyone take a look. There's no transmissible spongiform encephalopathy and no Jacob-Creutzfeldt's disease, which is known as mad cow's disease. So these are features, these are safety features of all of our patients. And now let me dig into the poster that we presented in 2023, autologous stem cell treatment for CLI patients with no revascularization options. This was an update mid-study, and I'd like to read through the study because there's a lot we can learn from this particular poster, including identifying patients, inclusion and exclusion criteria, administration of the cell therapy itself, and then also the safety and outcomes data to keep in mind. So the introduction to this poster and this phase 2 study is that we're using our autologous angiogenic stem cell therapies derived from a patient's peripheral blood through our proprietary technology. This was a phase 2 trial, an ongoing international multi-center randomized double-blind placebo-controlled clinical study to assess the safety and efficacy of ACP-01 injected into the lower extremity of 95 CLI patients who have no revascularization options. This is a slide on the study design. The major trial inclusion criteria: the subject is diagnosed with critical limb ischemia with one or more of the following hemodynamic indicators of severe peripheral arterial occlusive disease: systolic ankle pressure less than 70 mmHgs, toe systolic pressure 50 mmHgs for absent palpable pedal pulse. The subject is not a candidate for revascularization due to anatomical or physiological limitations. The exclusion criteria focuses on time to major amputation, primary safety, so that if a patient, if under the physician's care, the physician believes there will be an amputation within 4 weeks, that patient would be excluded from the study. The secondary endpoints, the ABI, TBI wound size, analgesia requirements, that's really around pain reduction in the calf, centered around the injection of the stem cells. And the administration methods are very instructive. So there's blood collection of 250 cc's of peripheral blood drawn and sent to our core laboratory for processing. We do have an FDA approved site in the United States with a clean room where the cells are cultured. It takes exactly 7 days from the blood draw to the cells being returned to the clinic, where the clinician will administer the cells. As noted, the central lab processes the cells of patients randomized to the treatment arm to produce no less than 5 million ACPs and are sent back to the participating centers for treatment, then injection and follow-up. The ACPs are injected directly into the designated leg, and patients are followed up post-treatment on days 1, 2, 30, 90, 180, 270, and 365, and annually thereafter. The way we offer, just a side note, the way we offer ACP-01 in the commercial setting is exactly the way we offer it in the clinical studies. We are running the care pathway and workflows exactly the same, the study as in commercial setting, to collect real-world data and for all the comments we're going to make around safety and efficacy of blood collection, cell processing, and then re-injection in the clinic. So I will now go to the next slide. I do want to mention here, I'm going to show you the official schematic of injection sites in the calf for both the treatment and the control arms. The patients have approximately 1 cc of cellular suspension or placebo saline injected directly into each of the labeled sites, with 24 in the leg, 24 injections in the leg, 6 in the foot. The injections on the gastrocnemius were performed with the patient in the lateral position directly into the posterior leg through the fascia into the belly of the gastrocnemius muscle calf. Injections were placed deep into the dorsum of the foot. This is the schematic of injection sites for patients that were enrolled in both treatment and the control arm. Again, I want to restate this. The patients have approximately 1 cc of cellular suspension or placebo saline injected directly into each of the labeled sites, with 24 injections into the leg and 6 in the foot. So these administration methods are part of our training protocol that every surgeon will receive if they choose to offer ACP in their clinic. That's extremely important. I'd like to show 2 patient case studies now that are part of the poster. This is a patient with ischemic ulceration. The patient had intact circulation to the mid-calf with no direct flow to the foot and occlusion of both the dorsal pedis and posterior tibial arteries. They were deemed to have no revascularization options. Picture A on the left demonstrates a dry wound involving the distal tip of D1 immediately prior to treatment. And then picture B, the wound has healed 4 weeks after treatment with no evidence of recurrence in this particular patient. Patient case 2 that will show you patient with large non-healing ulceration to the heel of the right foot. The patient had a history of 2 prior interventions, including a failed femur tibial bypass graft with prosthetic. A shows the ulcer at the time of enrollment, a large, mostly non-viable case. The patient had been offered below knee amputation for symptom palliation 4 months post-treatment, showing significant improvement. Concurrent treatment wearing an offloading orthotic and regular dressing changes were part of the protocol. So in this early view of this phase 2, 12 total patients were enrolled and looked at, 2 treatment centers, 10 were male, 2 female, mean age of 76 years, 83% success rate, specifically healing of ulcers and resolution of ischemic rest pain at 4.5 years of follow-up. The patient baseline conditions prior to treatment with ACP-01 or placebo: 3 patients had ischemic rest pain, 8 patients had ulcerization, and 1 patient had gangrene. Post-treatment, 1 patient with unremitting rest pain and toe gangrene did require a below-the-knee amputation, and 1 patient with gangrene of the 1st to 3rd toes required a 4-foot amputation. Again, healing of ulcers and resolution of ischemic rest pain occurred in the other 10. That's 83%. There were no clinically significant safety issues. Outcomes have been maintained for up to 4.5 years, 3.5 years for 2 patients, 3 years for 1. And 1 patient died after ulcer healing secondary to congestive heart failure at 6 months. So the conclusion of this study is that these are preliminary results. They seem to be promising with an acceptable safety profile and no ACP-related adverse events. Early data may indicate that ischemic wounds can improve or even heal completely with diligent wound care and follow-up and appropriate support. Further investigation and prospective study is critical to delineate an accurate prognostication. I'd now like to share with you the remainder of that study, which is ACP treatment, ACP-01, angiogenic precursor cell treatment of critical limb ischemia, decreasing ulcer size, amputation, and death. Re-examination of phase 2 ACP, no option, CLI trial data. Lead publisher Fraser Henderson, our chief medical officer, and you'll be able to meet him and speak with him and ask any questions you have at our roundtable that is coming up on November the 12th. So let's look at the study and the abstract itself. Critical limb threatening ischemia, prevalence in the U.S. of 1.33%, mortality of 15 to 20%, and major amputation 10 to 40% per year. Stem cell treatment has emerged as a potential treatment option for the 45% of patients for whom revascularization procedures are not possible. This publication, this study, re-examines the data of a phase 2 clinical treatment of no-option CLI patients with Hemostemix's angiogenic cell precursors, focusing upon ulcer, wound healing, amputation, and death rate. The study design, phase 2 prospective randomized double-blind study, evaluated ACP-01 and efficacy for no CLI patients who were not candidates for standard revascularization. The patient criteria, they met the task 2 definition of CLI with rest pain, ischemic ulcer, or gangrene, systolic ankle pressure below 70 mmHgs, and toe pressure of 50 mmHgs. The study protocol, patients are randomized 2-to-1 to treatment and placebo, monthly follow-ups for 1 year with VAS pain assessments, ulcer measurement, and ankle radial index. The key exclusions are major amputations detected within 4 weeks as the primary exclusion criteria for the study. The assessment and analysis for patients, the baseline evaluation, a full medical history and physical examination, the ankle brachial and toe brachial index measurement, CT or MRI angiography, the visual analog scale, the VAS pain assessment, and then ulcer measurement and photography. The monthly monitoring is pain assessment using VAS, ulcer size measurement, which is width times length, ankle brachial and toe brachial indices, and photographic documentation. Again, these assessments for the study will mirror how we monitor the safety, adverse events, and outcomes in any commercial setting around the world, so that rigor is executed accordingly in every clinic. The patient allocation of the study was 67 total patients, 46 on treatment, 21 placebo. This reexamination that's published was looking at patients who presented with wound ulcers before administration, of which there were 21 in the treatment group, 8 in the placebo group, and actually excluded patients that formed wounds or ulcers following the of the study. ACP-01 cell therapy, the manufacturing and administration protocol. Blood collection, a simple 250 ml blood draw from each patient yielded peripheral blood mononuclear cells isolated with the fecal gradient and subjected to enrichment media in our clean room at the FDA-approved lab, where the cells are isolated, enriched, and cultured to produce the functions that we talked about earlier, homing into the area of ischemic need, releasing growth factor, reducing inflammation, regrowing blood vessels, and ultimately restoring nutrients and oxygen to the areas of need. We'll talk more about the treatment administration in a minute. And no less than 5 million cells are administered, and up to 200 million maximum cells may be provided. So this is a shot of the process, but what draws my eye, and I hope you'll take a look at, are the intramuscular injection sites, of which there are 24 in the calf. There's 6 here in the foot, which will help guide you or your staff to administer the cells in your clinic. And again, be on the lookout for trainings in that regard. As it relates to results for our publication, the ulcer size in the treated group decreased from a mean of 1.46 centimeters squared to 0.48 millimeters squared. So I think about that as basically the size of a small strawberry to essentially the size of a grain of sand. So a significant wound reduction by 3 months. So 1.48 centimeters squared to 0.48 millimeters squared at 3 months. Statistically significant p-value, p0, 0.01. The amputation data is, I will share that with you now. You can see it on the screen. The placebo group had 2 amputations of 25% and 1 death, 12.5%. That placebo of 25% is actually in line with Medicare data. That tends to be an average, an industry average per Medicare data. And then the treatment group with ACP-01 had 1 amputation, 4.8%, and 1 death, 4.8%, in the treatment arm. And we're going to talk about that. It's important to know that the change in pain was not found to be significant in either group at 3 months, and at 1 year was improved in the placebo group. And I'll say more about that in a moment. Again, amputations in the treatment group, 1 out of 21, 4.8%, underwent a major amputation, patient number 30-501, at 73 days that we think was unlikely related to treatment. The placebo group, 1 patient, 1 out of 8, 12.5%, underwent a major amputation at 59 days. Then a second patient underwent amputation at 261 days. The difference in amputation rates says here was not significantly different, p value 0.11. We've talked a little about survival, 4.8% death rate in the treatment group, 12.5% placebo death rate at 1 year. Treatment amputation, 4.8% at 1 year. Placebo amputation at 1 year, 25%. Pain assessment outcomes. As mentioned, the change in pain was not significant in either group at 3 months. And I'd like to just read from the publication that Hemostemix has published. The author, Dr. Henderson, improvement of ulcer size in the treatment group was not paralleled by significant improvement of pain at 3 months. This does contrast with other studies in which pain-free walking distance significantly increased in cell therapy. The CD34 plus signature of ACP-01 may confer earlier ischemia relief in CLI subjects, as demonstrated in one randomized, single-blinded, non-inferiority trial in which trial patients were divided 1-to-1, receiving either purified CD34 plus cells or PBMNCs cells. In that trial, the CD34 plus group achieved faster rest pain. The efficacy of pain relief is thought to be complicated and may be variably influenced, either positively or negatively, by altered regulation of sensory nerve function and interneuronal activity and associated changes of N-methyl D-aspartate receptors. And so that's in the publication and worth taking note. The safety profile of ACP-01, the trial demonstrated no complications referable to the injections, notwithstanding the many comorbidities the CLI patients experience, especially with end-stage peripheral arterial disease at the no option stage, and especially among the group, the 45% mentioned that are not candidates for revascularization options. And as discussed, it's often due to extreme narrowing of arterial blood flow, among other complications. So the note here is that there may be minor symptoms at the injection site itself, transient rash, or maybe fever, but infusion toxicity, organ system complications, infection, death, or malignancy, and complications related to the stem cells themselves are almost unknown, and that's generally observed across all 298 patients that Hemostemix has reviewed in its 7 phase 1 and phase 2 safety data. ACP-01, the transplantation for cardiomyopathy, for example, and the 4 clinical studies in that space were associated with no complications related to the cells. So the conclusion of this study, the administration of ACP-01 within a program of careful patient follow-up is thought to be safe and associated with reduced ulcer size and decreased rate of amputation and death. Consideration should be given to readministration of stem cell treatments every 3 to 6 months to optimize improvement of CLI. Further studies, more appropriately powered, are warranted. And so we often talk about our clinical study protocols, of which there are quite a few at Hemostemix in phase 1, phase 2, and phase 3 for cardiomyopathy, angina, heart failure, CLTI, wound care, peripheral arterial disease, neuropathic pain, and then now vascular dementia. These are all downstream effects of ischemia and the blockages of blood flow. So you'll see that in our clinical trials coming up. We are and have announced the submission of our basket protocol. This is a broad phase 1 study that will treat many of these indications, upon approval through IRB and FDA review. And we often have talked about our vascular dementia study of phase 1 that we think is extremely promising. That is also has been submitted for IRB and FDA review, and we are hopeful to get that going in the next couple of weeks. So stay tuned for more information on those trials. And that leads into final comments on accessing care for our investigational platform. There's a lot of interest in the United States and around the world for regenerative medicine, and I would suggest everyone take a look at the FDA roundtable on gene and cell therapy that was hosted in May of 2025 with FDA Commissioner Macri talking about the importance of reshoring stem cell therapy and providing legal and safe pathways so people here and around the world can have access to safe and effective cell therapies. So far, just to recap, we've talked about our 7 phase 1 safety studies. We've talked about a safe profile. There have been a few deaths, but generally that's been attributed to the comorbid populations, not attributed to the cells themselves. And for the past couple of months, we've been talking about the availability for pain, managing pain, and for wound care in the state of Florida. For us, because we have an investigational compound that can reduce ischemic disease, there are lots of downstream effects through the heart and angina, through wounds, and other effects of ischemia that relate to pain and wound care. We are expanding our clinical trial offerings as discussed, and then we're expanding our global access points to care in multiple countries around the world to provide this important therapy that we hope vascular surgeons will consider, as in the case of this particular webinar. We also believe in breaking the cost cycle. What we've observed across CLTI or angina or heart failure or even vascular dementia, all of these end-state diseases, many patients have incredible surround sound care, but it's costly and it lasts for years. So many patients are under careful watch for many years without a chance for reversing ischemic disease and getting closer to healing and potentially even back to normal. Our cell therapy has an investigational review of that getting back towards normal in the case of vascular dementia, in the case of healing wounds, in the case of restoring blood flow to the heart. And so there is a break-even point where we're working with payers and regulators and all of our physician community to help our patients afford care in every way that we can to get them back to normal, in the case that we can demonstrate that in our phase 1, 2, and 3 studies. Our clinical care workflow is designed to make it as easy as possible in the case of vascular surgeons to offer ACP-01 in their own clinics. In other words, the process of a simple 250 cc blood draw, cells or the blood is shipped then to our FDA facility, in this case in Puerto Rico. The cells are cultured in the clean room and 7 days are sent back to the clinic for re-administration. Before that, establishing qualification is the most important step. So as physicians and patients engage with Hemostemix through our clinical trials, or otherwise, we take a careful look at all diagnostics for each patient. Our trained physicians may review them, or these patients may go directly to the surgeon, in this case to the surgeons on the call, to review the diagnostics, review the eligibility criteria, use the training materials that we provide, and make a determination whether this patient is appropriate or not. You'll recall earlier in the presentation we talked about patients that are within 4 weeks of a major amputation. They are excluded, for example. Meanwhile, there may be patients that are no option for revascularization procedures that you as a clinician, in discussion with your patient, may make a determination that ACP-01 is appropriate for that patient. The patient will then receive support and care relative to any travel support, any payment support, scheduling support, and any notifications and reminders so that the patient knows to come back for the monitoring, and as we talked earlier, on days 1 to 15, 30, 60, 120, 270, and then annually thereafter for monitoring and reporting. There are a number of access points to affording therapy, as discussed earlier, and as we're going to tackle in greater depth next time. We really want the democratization of our stem cells for every patient that qualifies here and around the world. And so we offer, at this stage, pre-FDA approval, pre-reimbursement, out-of-pocket financing. So there are several banks that offer healthcare-specific financing that will help you navigate towards to afford care with low monthly payments. And then we've also started a 501c3 foundation to provide support for those most in need. We kindly ask for any patient who can afford therapy for themselves to consider offering a donation to the 501c3 so that those dollars can be allocated to patients who may not be able to afford it for themselves. That we also have an investment vehicle for our investors called a treatment convertible debenture that is approved in Canada. Often our investors will also be sufferers of CLTI or other ischemic disease and would like to invest in the company while reserving therapy for themselves down the road as they consider care. And so that's what the treatment convertible debenture is. So you can ask and learn more about that as we go. I'd like to finally just close and say thank you for being a part of our community. We now go into a Q&A part of the presentation. There are lots of questions that generally come in. I tend to pause for a while. We have plenty of time on the clock. As people think of their questions, I will either attempt to answer them here on the chat platform, or please reach out to me directly. Again, my name is Kroom Lawrence, Chief Commercial Officer, Head of Patient Care. If you have questions about access to clinical trials, access commercially to offer ACP-01 in legal pathways, access to training, case studies, administration, how to follow up with payment, and access to the 501c3 to help patients afford care, you can direct all that to me, or I would strongly encourage you as well to reach out to our Chief Medical Officer, Dr. Fraser Henderson, and also our incredible Chief Executive Officer, Thomas Smink, who's been a champion of this company and this form of care and all the innovations and all the effort to bring this innovation to market for the past 20 years. He's an amazing leader, and we're grateful to be on his team. Thank you so much for listening, and I will now pause, and we're grateful to take your questions. So please add them to the chat, and if you're interested in a follow-up, feel free to send me a direct message, and I will get back to you immediately to talk about identifying patients, talking about the legal pathways. We can talk about the Florida legislation. We can talk about training for blood draw and administering cell therapy. and all the topics we've discussed today. So thank you again, and appreciate your time. So I will stand by for any questions. If you have to jump, great, but I can be on as long as needed. Thank you. It always takes at least a minute for people to form questions. There is no rush. I'll be here as long as you need. Okay, there's a great question coming in on inclusion and exclusion criteria. Who should I be looking for in my clinic? What I would say is I would refer you to the Phase 2 publication by Henderson in the Journal of Biomedical Research under Vascular Medicine Trials. In that, we talk about patient characteristics for who was included and excluded from the trial. And so I'm going to just quickly read that because I think it's an essential question. So if you'll just give me a moment, I'm going to pull up that data. Please stand by. So typically, as discussed, patients or people who are qualified for ACP-01 are not candidates for standard revascularization because of either failed revascularization attempts, specifically lack of runoff vessels to the foot, or because they were at significant mortality risk. So patients that meet the Task 2 definition of CLI with rest pain, ischemic ulcer, or gangrene, a systolic ankle pressure below 70 mmHgs, and a systolic toe pressure below or equal to 50 mmHgs are generally thought to be included. The exclusion criteria would take into account those at risk of a major amputation within 4 weeks, or a life expectancy less than 6 months, or uncorrected aorta-iliac occlusive disease, or active infection of the lower extremity, or advanced CLI ischemic ulcers that are larger than 10 centimeters squared, or severe aortic stenosis grade 3, or diagnosis of malignancy within 3 years of the study's onset. So that is a discussion of inclusion and exclusion. I would recommend you join us at our roundtable on November the 12th to discuss any questions you have. Or please refer to our study documents and our training documents. So I will now pause for the next question. And thank you for that question. There's a question on the inclusion criteria, or it's actually a question on the access to care in the state of Florida. So Senate Bill 1768 was activated on July the 1st of 2025. That legislation has passed and specifies orthopedic care, chronic pain, and wound care as areas of potential treatment, so long as the physician stays in their clinical swim lane. So a wound care specialist will treat wounds. Vascular surgeons can treat CLTI as it relates to pain and wound and in the context of amputation. The doctor must disclose clearly and prominently to the patient that ACP-01, they are investigational cells. And so that is essential for the patient to have informed consent before there is agreement between you, the doctor, and your patients to proceed with ACP-01. Here's a question on the guidance for injection. And I think this is great, and I appreciate the opportunity just to sort of restate this information we covered earlier. So let me just hit this again while I have you. So, and I'm going to refer to the methodology of administration in our publication. So each patient has 250 cc's of peripheral blood that is drawn in a simple blood draw in the clinic and then sent to our laboratory for processing. Our lab processes the cells of patients with no less than 5 million ACP cells and as much as 200 million. They're sent back to the participating centers, your clinic, for treatment. The ACPs are injected directly into the designated leg, and patients are followed up post-treatment on days 1, 2, 30, 90, 180, 270, and 365. I do want to flip back to this picture because I think this is important just to have a visualization of the administration of ACP-01 in the calf and in the foot. So you can see that very clearly. I would suggest please to look at our guidance and training on these injections exactly as to the amount of fluid and into the depth of the delivery. It's also important to discuss any pain relief for patients that may prefer that in the mode of administration. So we do have guidance on that. So we can cover that. If you would kindly reach out and set up a call, we can discuss that together. I see a question on the molecular biology of ACP-01. I think this is incredibly interesting. We covered this a little bit, and there are 4 or 5 ways, actually 5 ways, specifically where the molecular biology of ACP-01 can deliver its impact. So let me just cover this from the publication. So ACP-01 improves microcirculation in 5 major ways. First, ACP-01, they're programmed to form endothelial cells, the major constituent of blood vessels. Second, the ACP-01s exert a potent paracrine effect, secreting vascular endothelial growth factor and angiogenin, directly promoting angiogenesis and the generation of new capillaries through the proliferation and luminogenesis with potent levels of vascular endothelial growth factor, VEGF, and angiogenin are secreted by ACP-01. Third, actually, as you can see on the chart here, ACP-01 increases expression of interleukin CXCL8, which enhances angiogenesis through the RAS, MAPK, PI3K activation, and the AP1 NF-KB axis. Fourth, elevated CXCLs mobilize an additional reservoir of endothelial cell progenitors, such as peripheral CD34 precursor cells, which amplify the angiogenic response. The importance of CD34 is demonstrated in a study of no-option CLI patients treated with bone marrow mononuclear cells, those responding with limb salvage and wound healing, and had significantly higher CD34 cell dose compared with non-responders that required limb amputation. Finally, ACP-01s promote the migration of CXCR4 receptors present in the ACP-01 home, and they home in toward the specific alpha chemokine CXCL12 ligand expressed in injured or ischemic tissue. So, as sort of noted earlier, these cells go to the area of ischemic need. They form growth factor, they reduce inflammation, they restore and regrow blood flow, And that is sort of the heart of the mechanism of action of these cells. I think that's important to contrast versus bone marrow derived mesenchymal cells or just natural stem cells that aren't cultured in this way. I think we would attribute the safety and the outcomes data to this particular MOA, which is in alignment with our patents and with the awards that we have won in the breakthrough technology of culturing these cells. Those are the key questions coming in that I think aren't duplicative to some of the things we've already covered. Please, I would encourage you to come back every week to VesCell Health Talks, whether you are here in the US or around the world. We encourage our physicians, our patients, our regulators, anyone in the cell community to learn more about regenerative medicine. Our transparency comes directly from our studies. We live out of all of our publications. I would encourage everyone to read them in detail. Please also review state-level legislation, review FDA-level legislation, so that we are always in accordance with what is a complicated overlap of regulatory environments, whether they're global, ex-US, or here in the United States, or in state by state, so that we're always operating comfortably within the guidelines as established here and around the world. I'd like to thank you for joining us. I hope everyone has an excellent rest of your week. Please look for archived versions of this discussion on YouTube, on X, on Instagram, on Facebook, to try to serve everyone in our community. Thank you so much. Please reach out to me directly, and we'd be happy to set up a call to discuss further. Have a great day, everyone, and be well. Thank you. Please come back and see us.